And I talked to my plastic surgery advisor from medical school, and he's like, oh, just do ENT. It's just like plastics of the head and neck, which if you're a plastic surgeon is probably true. But if you're not a plastic surgeon, it's actually not true at all.
So, ladies and gents, listeners all around the world, welcome to the Rhinoplasty podcast with me, Dr. Cameron McIntosh. We are super excited for this month of April to have the leading ladies in rhinoplasty around the world. And kicking off this month is a lady who comes all the way from the United States of America. And we have to say thank you very much to Pentax Loops, who've made this podcast possible. Pentax Loops are saving my neck, and I think they might save your neck as well. So if you listen right to the end of the podcast, I'm going to give you the link to click on and send a message to and ask for a great discount on Pentax Loops. But first, you have to listen to this person. So I'm very excited for today because this person we've got who's going to be speaking to us it's quite astounding. She was one of our chief judges at the World Rhinoplasty Day. She's the facial plastics section editor of the Laryngoscope Journal. She's a professor at Harvard Medical School, and she's a mom with 3 kids. So, Robin Lindsay, welcome to the show.
Thank you so much for having me, Cameron. It's great to be here.
So, Robin, it's just great. I've met you a couple of times, and I'm just enthralled by your enthusiasm for rhinoplasty, but also the professional way that you go about rhinoplasty. So I know we're going to be chatting about some rhinoplasty things later, but I just want to kind of get in what makes Robin Lindsay? How did you end up being a professor at Harvard? Where did this whole journey start for you?
Yeah, I mean, I think, you never know where life's going to take you as much of a planner as most of us are. And I think you have to kind of enjoy the journey. So I grew up in Virginia. My dad was in the Navy, and we lived overseas in Japan for a while, and then came back to Virginia, where I went to undergrad and medical school. And I think, we all have those experiences where the first time we're in the operating room, we're like, this is where I have to be. And I sort of started on that kind of journey actually through orthopedics and then general plastics with hand surgery, and really loved sort of the anatomy and the nuance of that. And I, as chance would have it, ended up having to do a plastic surgery rotation because orthopedics was full. And I was like, this is even better. Like, you get to do the face and body, and this was fantastic. And, I spent a lot of the end of medical school doing, sub-Is in different locations at UT Southwestern and others. Like, this is what I want to do with my life. But I had gone through what's called the Health Professional Scholarship program for medical school, which is where the military pays for your medical school education. In return for that, you owe them time. And so at that time, the integrated plastics programs were new in the U.S., and they were not an approved pathway of training for folks who had done this pathway. And so they were like, nope, you can't do that. You got to either do ENT or general surgery. And I talked to my plastic surgery advisor from medical school, and he's like, oh, just do ENT. It's just like plastics of the head and neck, which if you're a plastic surgeon is probably true. But if you're not a plastic surgeon, it's actually not true at all. So I was a little bit of a rude awakening starting residency, having learned a lot about facelift and cleft lip and palate and breast reconstruction, et cetera, and not a lot about the temporal bone. I clearly knew when I started residency that I was going to, end up doing, either, general plastics or facial plastics. And so that's sort of what, led me into that field. And, I was fortunate enough to do fellowship at Mass Eye and Ear many years ago now. And I think, that experience was mostly in, facial nerves, but really high volume outcomes research. And when I returned to the Navy after that experience, because I still owed them some time, I was able to sort of take what I've learned from outcomes research and then adapt that to rhinoplasty, because young, healthy people in the military and their family members can't breathe through their nose, and they're concerned with the way they look. So I think that was sort of, I fell into that niche because those were kind of the patients available, and that's just kind of continued to grow over time, which has just been a fantastic areas. I think everyone who is in this field, really so much values this patient population and what we get to do every day.
So now, as one of the leading ladies, how was it for you as a woman getting into this, in a way, very male-dominated rhinoplasty world?
Yeah, I mean, it is very male, dominated. And I think you just really have to sort of enjoy, what you do. I think, I was, probably, one of the few, female, residents in otolaryngology at the time. And I've, been out of residency training for over, 15 years now, and, graduated from medical school in the late 90s. And, at that time, there weren't a lot of females going into surgery, and certainly not a lot of females who decided to have kids during residency. So that's another.
So talk to me about that.
Experience.
I can still remember we had our third baby a week before my final written exams of ENT. But like, I can at least get away. I'm not the mom. How do you handle having kids during your residency?
I think you have to have a lot of support. My husband's also a physician, but I think, my parents and my sister certainly helped out a ton. And I think I don't know, looking back at it now, I'm not exactly sure how we did it, but it was certainly the right thing for us to do. And I'm like, thrilled to have the three. And I had one, my oldest, who's now 17, I had while I was a resident during my research block, very well timed. And I had my daughter 6 days after I graduated from residency, also well timed. And then I had my youngest, who's now 10 after I completed fellowship. So I think you have to sort of pick those times in your, training that can make it work, but you still need a ton of support from everyone.
And Robin, how do you balance your family life with your professional career? I'm specifically asking this question more for the female listeners, because I just feel there's such a need for an encouragement for women who have this dual role of having to try to run a home and also be out there working at the same time. So the question is really asked towards somebody who's listening to this, saying, how do I actually do this?
Yeah, I mean, I think, the way I try to advise like our, medical school students and, residencies who are, already in a surgical subspecialty are considering that. I mean, I think you have to realize that there's no perfect time, as, the men in the audience know as well, to have kids. There's never a 20-year time period where you get to like take off from your life to have them. So you're always going to have to, balance what you're going to be able to do from work and what you're going to be able to do at home. And I think you have to, be gracious with yourself, because I think most of us in this field particularly are very much perfectionist. And you have to realize that you're not always going to be able to do everything all the time as well as you want to do it. And you just have to be kind of gracious with yourself and those, around you. And and I think what I've kind of learned over time is that it's important to, give yourself a little bit of time with the kids. We all work really hard. We work long hours. There's so many days where you can't leave, the OR, and you just can't leave work to be home for dinner or to be at the bus stop. And I think as you progress through your career, if you can sort of organize your schedule so that, there's a day every, week or so where you're the one doing the school drop off, or you're the one doing the school pickup, and, giving yourself that time and flexing your schedule, you're actually not working less, but you're able to flex your schedule enough so you're not missing those really important kind of moments for your kids all the time. And at least you know what it's like to be at the bus stop. You've seen the other moms that pick up, and you're not this mystery person who works all the time. And I think those are the types of things. And getting ready to have one heading off to college, you realize how quickly those years go by. And those are really those priceless, memories that you hold with you. So I think it's just a matter of, when you have that person that you want to have kids with, is that, just fitting it into like your schedule, but realizing that, just putting off is not always the right thing to do, because there's never it doesn't get easier when you're an attending or a more senior attending. It's always work.
Well, that's awesome, eh? And what do you do when you're not working and you're not hanging out with the kids and your hubby?
Well, I've been thinking a lot more about this, that I need a hobby, because as the kids are getting older and I no longer have like the 3 elementary school kids that you have, you realize that they don't need as much from you. And they're sort of, slightly, starting to distance, themselves. And, you sort of have to value that time when everyone's together even more. So I certainly need to kind of, think about more hobbies as we move through. But, in the wintertime, I did not grow up in the north, and neither did my husband. So, the cold weather was sort of a bit of a transition. We've been in Boston for over 10 years now, so I've adjusted. But my husband used to say I had seasonal affective lazy disorder, and that in the wintertime I would just like sit by the fireplace, read, and like not go outside because it was so cold. So he really encouraged me to like get out, and we started skiing, and it was a great family activity. And so I have to say that's for the winter months, which from here is really from, late November all the way through April, actually, is that, skiing is a great way to kind of get outside, especially in the long winter months, and it's bright and it's active, and it's something that you can do with the whole family. So that's really what I do through the winter. And the summer months, we move more into sort of gardening and water skiing and hiking and that kind of thing. So and try to stay busy.
There's no snow skiing in South Africa, that's for sure. Now, Robin, I want to change direction slightly. I'm so intrigued with your role at the laryngoscope. Tell me a little bit more about what you do there and how you ended up being in that position.
Yeah, so I've been in that role for a couple of years now. And I think, you usually start off with the journals, just by starting to be a reviewer. And so I think when you start getting reviewers, and we're always looking for really excellent reviewers from all over the world to review for us. And, and it actually is pretty challenging to get really good reviews. And I think so many, when you're submitting your manuscript, so many hours of work have gone into that. We want to make sure that we're giving each manuscript their due. And so a big part of that is really having excellent reviewers. And so I think it really starts out that when you're asked to review something, one saying yes, and then, giving the respect to that manuscript that you'd want for something that you had submitted as well. And so I think you start off doing that. And I think the way in which they kind of pull to, the other roles of the journals are really looking at sort of those excellent reviewers who've really kind of time and time again said yes and not declined and really submitted excellent reviews. So I think that's the way I eventually progressed to the kind of associate, editor position. And it's been really fun because you get to see everything that really comes into the journal. You get to see what everyone writes as, reviews and kind of the way their take on things. So it's really a great kind of insider look into our field.
And so of your day, I mean, if you're in your week, how much time are you spending in the clinic seeing patients? How much time are you spending in the OR or the theater? And how much time are you spending with a laryngoscope?
Yeah, so I typically operate 2 to 3 days a week. So I operate every Monday, Wednesday, and some Fridays. And then our clinic typically it's changed a little bit because of COVID as we've tried to space things out. But I'm typically in the clinic sort of one long full day a week. And then I have a day a week that's sort of dedicated to, which is today, that's dedicated to more academic endeavors. And so that, I think that's for kind of younger viewers is that really, take advantage of that time. And it's easy to like have, oh, sure, I'll see that one patient or go to the OR, and you have to do that early on. But when you can start kind of really valuing that time and protecting it, it's very useful. And so, a lot of the editorial stuff gets done there, though. I mean, things are submitted throughout the week. So it's probably almost like every other day or so that you're sort of online on the laryngoscope, website, looking at the reviews, finding reviewers. So,
and we're not chatting to Travis. He said that there's just been a plethora of more submissions to them because of COVID. People have now got time to actually write up all these articles. Have you guys found the same?
Yeah, I think, it's interesting. We saw a ton of submissions sort of, a month or two after both of us were going into quarantine. And so there was a kind of a huge uptick at that time and probably throughout the summer. I would say right now, I think that, and I haven't looked at the exact stats, but just sort of a brief overview of how many we're sending out for review now. I feel like it's kind of, there's been a little bit of a downturn probably as folks are going back to work. Typically February is a really busy time for laryngoscope because of the meeting in January, that if you have an abstract that's accepted or a poster presentation, then you have to submit that to laryngoscope. And so for people who have done that, they're all submitting it in January. And so there's a huge uptick in February from that. And I didn't see as much of an uptick this year.
Okay. And now, Robin, I just want to chat to you a little bit about World Rhinoplasty Day. So this was quite a kind of unique event that the South African guys put together. What are some of your thoughts of being a judge? Because we really wanted to make this a good scientific meeting, because we found that there's been a lot of people kind of doing what Rod Roerick loves to say, of saying everyone's world famous on their own website. So we felt that it would be good to have these people head to head, but do it in like a fashion of a sports event where we've got judges calling it. And it was really great to have you guys, and I'm going to be speaking to Barman soon as well. How did you find the level of the event, and how do you think we should possibly change it, etc.?
Yeah, I mean, I thought the event was incredible, kind of on multiple fronts. I think I think all of us were just so hungry to like just see each other and engage in another way. And so, after being kind of in quarantine and not being able to do our typical, rounds of meetings every year. And so I think it was just very fulfilling from that standpoint. And then I think it really did sort of, increase the caliber of, what we expect from rhinoplasty around the world. And I think it also is a forum to let, folks know that, we're all, reading journals and doing this, but like, there's just folks that you just don't come across like as commonly. And so I think one of the things that I really enjoyed in going through and reviewing the videos is that, as we broke this up internationally from different countries and different regions, you really were able to see these great up and comers. You definitely saw the senior people that and love watching their talks and have so much respect for, but you also saw these great people who you just see like as the future of rhinoplasty as well. So I thought it was a great forum from them. And then, so many of them really just like, knocked it out of the park. And I almost feel like if you're doing this again, that you should almost have like a, like some sort of award, because for like none of them are newbies that are presenting. They've all been doing this for a while because they truly do have something to say, but sort of like an outstanding, new topic or something like that. Just to like, I felt like there were people that I wanted to give awards to that weren't fitting into those like top three, but I so wanted to acknowledge as well.
Yeah, and I said to you guys, we're not going to have a tie. We have to make the call. So that's actually quite interesting, because in May so the schedule for the Rhinoplasty podcast, I want to always put it out too soon, but in May I've got it as the Young Guns. So I've got 5 of these guys from around the world who aren't like necessarily yet the rock stars of rhinoplasty, but they're going to be speaking. And then after that, we're moving to some senior guys. And so it's quite nice to kind of have a platform where we can have so many varied speakers, and we don't always listen to the same brilliant guys speaking, eh?
And I think that's so important. I think that's both for the younger men and women. And you were asking earlier about, getting your start in, rhinoplasty and as a woman. And I think, one thing that helped me is, just really getting into the outcomes, measurements very early on, so that you have something to say and you start publishing and get your name out there other ways as well. But it also really takes sort of sponsorship, both from, men and women, to say like, what, she really should be there and have something to say. And I remember, several years ago, and in the U.S. at the rhinoplasty meeting, Theta Contis has always been a huge proponent of women within the AFPRS in the U.S. and was really like there was like two females. I think it was, she and Roxana on the rhinoplasty. She's like, guys, like we can't have a 4-day meeting with 2 female speakers. And so, back then, then Lisa, Ishii, and I were asked to like come join. And it really is like us in like a sea of dark suits. It's like, we really all should be wearing a bright color. So we stand up and, and I think that was, 8, 9, 10 years ago now. And so really, I think we've taken off from there. And certainly, I think as we look in the meetings more recently, there are more female speakers. But I think we really have like, ways to go, on that front. And even sort of these big multi-institutional or, manuscripts or position papers that are, put out through, plastic surgery or facial plastics or ocular, like we really need to look at sort of, the demographic of that to ensure that we're, including folks internationally and, of all different backgrounds and gender. So I think that's something that is certainly on the forefront of many people's minds, especially now, but we should take a look at it in our own field as well. So I think events like this that help to sponsor, women and up and comers is just fantastic.
Yeah, no, it's fantastic. And it's great to speak to you about like the groundbreaking work you guys have done. But tell me, when have been the times where the flame's been low? What have been the hard times for you as a woman in rhinoplasty?
I think we all go through those struggles where you've like worked really hard on the manuscript and then you submit it and you get these reviews back and you're like, wait a second, and it's just like, and it's a little, low and you have to like, oh, this is so discouraging, or you submit grants and then it's not funded, and so much time and effort, goes into those projects. And I think that's where you just kind of have to like dig deep and just say, all right, we're just going to keep pushing forward, and eventually, it's going to happen. And I think also, when you're looking at sort of the reviews of, manuscripts and grants and things, like if you have mentors that you can talk to about that can really sort of advise you, a lot of times, sometimes they're not, but a lot of times the critiques are, very helpful. And if you can say, okay, well, this is where I can move forward and make this even better, you'll become even stronger in the long run.
Yeah, I think you need to kind of separate a critique from yourself. They're not criticizing you as a person. It's just
right. But it feels personal when you first comes back, and then you have to take a deep breath and then put it down for a day or two and then re-engage. And then it's the right time to look at it.
So Robin, I know you also want to share a little topic with us. Please feel free to share your screen, and I remind you that because quite a few people won't be able to see the YouTube video, they'll be listening to you. So just bear that in mind whilst you chat.
Yeah, no, absolutely. So I think, one of the topics, you asked us to kind of pick a favorite topic of ours. And, my, topic that I really, have become, more and more passionate about is, let me just switch in through here, is really kind of the form and function of rhinoplasty. And so this is kind of a snippet from a talk that was given at the rhinoplasty meeting in Orlando a couple of years ago. But I thought it sort of nicely, highlights, what, do we consider to be sort of a beautiful nose. And I think that, for us, when we look at a nose, patients have their concerns both functionally and aesthetically. And even their functional patients don't want a larger, less attractive nose. And so it's really our role to diagnose the underlying pathology, and then to understand how we're going to give them both a functional result and an aesthetically pleasing result. So I've been using the sort of nose scores, for a long time. And that really has helped me to sort of look at my, functional patients. And then we started using several years ago, we started using also validated patient-reported outcome measures, looking at nasal appearance in addition to their symptoms of nasal obstruction. And obviously we were using this on our aesthetic patients, but really I think where it provides a lot of value is on our functional patients, because we want to demonstrate to patients that we can get them breathing better through their nose without a negative aesthetic outcome. Because many of patients come to see me and they can't breathe through their nose, but they've been told by their general otolaryngologist or their primary care doctor is like, oh, you don't want to have that surgery because it's going to give you an ugly big nose. And I really don't feel that that's the case. And so we wanted to put some data behind that. And so we were able to use the FACE-Q score and the nose score. This was published several years ago. In the facial plastics, is that that we can both make patients breathe better through their nose without a negative aesthetic outcome. And many of them, in fact, actually feel like their nose looks better. And I think this is the satisfaction with nose scores, and this is just pulled from that manuscript. Where we have patients who, this top patient up here, was very concerned about her aesthetic, but couldn't breathe, but we weren't making any aesthetic changes. And she could breathe through her nose afterwards, and also was even happier with the appearance of her nose. And this is more of a trauma patient who also couldn't breathe. And, we're improving her breathing and not making any discrete aesthetic changes, but clearly, functional benefit from correcting, her middle vault narrowing and dorsal deviations. And then as well, the bottom patient has a very thin, long nose, and, dorsal hump and narrow middle vault. And so by making some aesthetic changes, we want to bring down his, dorsal hump to improve the aesthetics of his nose, but we also want to maintain his breathing. And so I think these are, good examples of where we are taking into account both the form and the function of the nose.
Awesome. I mean, they fit hand in glove. What I find quite interesting is a patient who tries to come in and act as if they have a functional problem, but they actually don't have a functional problem. What are your little tricks to catching people out who are trying to cheat the system?
Yeah, I mean, I think a couple of things. I think, one, every patient that comes into my clinic gets the electronic patient-reported outcome measures. So we're collecting the nose scores, we're collecting the face Q scores. We also do some sleep measures and snoring measures as well. So that's one way to sort of assess that. Pre-COVID, we were also doing the PNIF, or the peak nasal inspiratory flow meter on everyone. I don't think that can really be used as a diagnostic, though it does help kind of pre and post. But I think if you're certainly seeing very large volumes, like, well, they're probably breathing okay. And I think the other is really the questioning about breathe right strips, as well as doing sort of the Q-tip maneuver. And if they're really not getting any benefit, if you're looking in the nose and the septum straight and you're doing a Q-tip maneuver, asking them about breathe right strips, and they're like, oh yeah, that doesn't really help at all. It really calls into question if there is a breathing issue or not. I also find the other is true, that patients come in with a functional, with an aesthetic concern, and they also have very narrow nasal valves or deviated septum, and they just, you look in their nose, you're like, you're probably not breathing all that well. But that's the way that they've always been breathing, through their nose, and they just don't really know. And so in those patients, I do sort of explore further and get them to try breathe right strips or try the Q, just to see if they have improvement. And, sometimes there's not a difference, and sometimes it's like, wow, that's like so much better. I didn't know I could ever breathe like that. And so I think even in our aesthetic patients, we should still ask those questions about breathing, because if we have the opportunity and we're there to make it better, we should really fix that as well.
And then often what we find with medical insurance in South Africa, so I'm working in the private sector, not in the state sector. So medical insurance will pay for a functional rhinoplasty, and you'll have somebody like that come in and they've now saved up and they want this cosmetic rhinoplasty. And you show them how terribly deviated their septum is, or you do, I use rhinometry testing and see that the one nostril is completely blocked, and suddenly medical insurance is going to pay for their rhinoplasty, and they're very happy with that.
Yeah, I mean, we have to be really careful in the U.S. And so even if we're doing functional and cosmetic at the same time, I think the U.S. insurance system's gotten very, very savvy, and like they read through our operative notes. And so you have to be very careful with discreetly separating out sort of the functional changes from the aesthetic changes. And so we do charge, if there's any cosmetic changes at all, there's always a cosmetic fee associated with that. And so the breathing part will go through insurance, and then there will be a cosmetic fee associated with any of the discrete cosmetic changes. And so, sometimes if there's a very, deviated, dorsal deviation, in order to get them breathing better, the nose is going to be straighter. And if that's kind of the only change they want, then I consider that to kind of fall under just the functional operation, because I'm not doing anything different, but if they come in and they're like, oh, I've got this like hump here, my tip's a little, if I'm doing those type of tip aesthetics or, dorsal hump reductions, like that falls into the, the cosmetic realm. And so just explaining to patients that, that sort of goes outside, not really impacting your breathing. And so we can do it at the same time, but we have to separate that out so the insurance will apply the other. Because what happens in the US is they'll actually deny the whole thing. So if they get an idea that you're trying to do cosmetic changes at the time of a functional operation and you're not charging a separate cosmetic fee, they'll actually deny the entire procedure. And then the patients get a giant bill from the hospital. So we try to prevent that as much as possible.
I mean, I remember when I was studying Ira Popel's facial plastic surgery book for the board exams, with one line, there's a quote that it said, if a man or woman has integrity, nothing else matters. Yeah. Or if a man or woman does not have integrity, nothing else matters. And it's so true. If you just make a small little, it's actually, it's going to come back to bite you as well. Eh?
Yeah, and I think that's where I really learned, and it was a little bit of a challenge up front, because having been, and I was on active duty in the military for 12 years, and so my initial practice started there, and there's no insurance. It's a global care, so we're not having to submit to insurance covers. Like if patients need something, then we fix it. And so, when I came to Boston, and now you're dealing with the pre-certification process and insurance reimbursements, you really have to make sure that you're documenting, what you see, but also using the terminology that they need for approval. And you have to be really, careful with that documentation and really separating out that cosmetic changes from the functional changes, because I think the insurance companies are looking for any reason not to approve or not to deny. And when I tell patients, like, that's really why it's so important to separate those two out and have a charge the cosmetic, is because we don't want the functional portion to be denied. And we don't want, just kind of globally, for all patients who need that care, for insurance companies just to now decide that this is just a cosmetic operation and they're not going to pay for it anymore. So I think it's that stewardship that all of us kind of need to be accountable for. I think exactly as in the very wise Dr. Pavel, if you have integrity, there's not a problem.
Tell me, Robin, in terms of CT scans and cone beam CT scans preoperatively, do you use that in the practice?
So I don't. So my practice is pretty niche at this particular time, and I have a large referral base from general otolaryngology and rhinology. And so a lot of the patients have, if they've needed a CT scan for evaluation of sinuses, I don't typically, they already come with them. I don't typically order them preoperatively, standardly, for patients with nasal obstruction. And then for ones who've had it preoperatively, through general otolaryngology or rhinology, we typically don't order them postoperatively unless there is, some concern that we're evaluating. I think it's a challenge, right? Because I think with CT scans, because there is an additional, radiation dose, the radiation exposure to a CT scan is about equivalent in the US of flying from, Boston to LA and back. So the overall radiation risk is pretty low, but we do have to consider that. And I think that comes into play with sort of some of our computational fluid dynamic modeling, where we need the CT scan data to do those analyses, and even trying to get sort of that through our, institutional review boards to get approval for research, is because those CT scans do, flag when you're doing them for research purposes. But, the consensus statement that was written probably about 10 years ago or so, really kind of tried to suggest, that, CT scans were not needed for diagnosis of nasal obstruction, because many insurance companies were requiring a CT scan, prior to nasal valve surgery, and sort of trying to move away from that.
Okay, so one more question in around that is, if a patient does have sinus issues and you might have to do some kind of sinus surgery, do you do it at the same setting as the rhinoplasty?
So typically, Mass Eye and Ear is a very, very niche work environment, and we have lots of rhinologists. And so a lot of those patients are seen by rhinology first and need sinus surgery. So typically I will, if they need sinus surgery and it's not substantial amounts of sinus surgery, we do try to do them at the same time. So, and typically I always have my rhinology colleague go first, because I don't want their scope in the nose after I set it. It's not just me being nice to let them go first, but I think that actually works out quite well. I think a lot of the rhinologists, if they're doing kind of an extensive, sphenoid and frontals, and it's going to be a several-hour sinus procedure, then we'll typically stage it, and we'll stage it really based upon what the septum looks like. So if the septum's looks reasonable and they can do what they need to do, then typically they'll go first, and then we'll bring them back in a month or so for the rhinoplasty portion. If they really need the septum corrected beforehand, then I'll go first and fix the structure of the nose, and then once they heal from that, they'll go in and do the sinus surgery.
Awesome. Okay, so there are two last things that I'm quite interested to chat to you about, because you've had this incredible career where you're kind of at the pinnacle now, still lots to do. So on the one side, I want to know, where do you think rhinoplasty is going? And on the other hand, is specifically aimed towards women who are now getting into this. What would your advice be to them? So maybe the first question is, how do you see, because COVID's changed so much, education's changed a lot, but where do you possibly see rhinoplasty progressing over the next, say, decade or two decades, being the editor of such a big international journal?
Yeah, so I mean, I think that we learn so much from those folks who have been in practice for longer than you and I, and really the way in which we've learned is by following their outcomes. And one of the reasons I got into sort of this patient-reported outcome measures after rhinoplasty was going to the rhinoplasty meeting, sponsored by the American Academy of Facial Plastic Surgery, I think back in 2006. And I was just a little bit out of residency. And back then it was sort of a one-room meeting with about 500 people. And the nose score had just started being used by just a couple of people. And I remember, Dr. Toriumi, presenting on lateral strut grafts and, using the score. And I was like, you know what, this is what I want to do. We got to figure this out. We got to figure out which graft is better than what graft, and sort of watching how he had sort of changed his practice over time by following results. I was like, that's what I want to do. And so I think, we learn from our own practices and for each other by continuing to follow those outcomes. And so I think, from a photo, taking really meticulous, photo documentation, being really honest with yourself about your results of what's working, what's not, listening to your patients. And I remember the placement of a rib graft scar, initially was sort of described, by Dr. Gunter being more lateralized. And then I realized in my military population, men didn't care if it was on the side or in the front. It was a lot easier through a smaller incision if you place it more medial, and women don't want that incision right in the inframammary crease, because even though it's aesthetically and covered up, it's uncomfortable for them, wearing, a bra. So placing that a little bit further. So you really learn so much about your patients, and don't make lateral curl strut grafts too long, because when people blow their nose, they click,
But no, sorry, I need to stop you there. On this incision for the rib, I've never heard that before. I've only heard men presenting about where they put the incision. Just remind me again what you said there.
Yeah. So, if you talk to women about the placement of that incision for the rib graft, if you place the incision right in the inframammary crease, it's really uncomfortable when you wear an underwire bra, because the bra is sitting right on that incision line, and it's uncomfortable. And so, especially in women with larger breasts. And so if you drop that scar, that incision line, just down just a few millimeters, they're still able to wear a bathing suit. You can't see it. It heals very well, but they don't have that same discomfort post-operatively. So it's a really small, change in your placement that makes a big difference for your patients. And, I think things that with rib grafts is you're not cutting through the muscle, meticulous dividing, and it really just helps so much with the postoperative pain. So I think, learn from your patients, follow your outcomes, and, be willing to sort of change your practice based upon what you're seeing. And I think the hardest thing that we have to do is that, we see these great new techniques and you sort of want to jump on board and try them. And I think the hardest thing to know is when do you integrate that into your practice? You're getting really great results in what you're doing. And I think that dorsal preservation, rhinoplasty is just a great topic right now. It's okay, wait, I'm getting really good results the other way, but there's this really exciting new technique. And I really respect and value the opinion of all these great people who are talking about it. When do I make this transition, and which patients do I start, and how do we follow our outcomes there to make sure that we're actually, getting the outcomes that we think that we're doing. And, that's something that we're going to do as a field. And so I think that those are the types of things that over the next 10 years, I think more and more people, secondary to sort of, these world rhinoplasty events where you're presenting and it's use your outcome measures. I think so many more people are doing that worldwide, and we're going to get to learn what other people's results are, and hopefully just being open and honest, what, I tried that, didn't work. This seems like it's better. And that's how we're all going to grow. And at the end of the day, we want to take amazing care of our patients, and that's kind of the ultimate goal, and that'll help us to do that.
Oh, that's awesome. So, Robin, my last question then, for the ladies who are listening to this. I mean, it's great. You're the first of our 4 women who's speaking on the leading ladies for the month. What would you say to the girls out there?
Yeah, I mean, I think that it's absolutely possible to have the career that you want. I think, you want to find, mentorship and sponsorship in many different areas. And that's going to be from, women, it's going to be from men, it's going to be from people who may sometimes even be junior to you. They're doing like new, exciting things that they've learned in their training. And so I think if you're always keeping your mind open to sort of learn from all of the folks around you, and then, having sort of your, trusted colleagues that you can really, there's so many of us now that, we'll see each other's difficult patients, or we can like call them up or text and be like, oh my God, I got into this situation, what do I do? Or I saw this patient, what's your idea? Or can I come watch you off? That's, I think the hard thing with COVID is we haven't been able to come and, visit and watch, but can I come like watch you do that technique before I start? Because I really want to make sure I understand it before, I integrate that into my practice. And so, and some advice that I got from some female surgeons a long time ago at a leadership meeting was that, when you go to a meeting, go to the meeting and, sit up front, ask questions. And it's amazing how that simple act of like really attending, asking questions, like staying after the coffee break and being brave enough to go like up to folks that you've like admired for so long and have been the names in the textbooks and the chapters and articles, and just go ask them their opinion. And people really are in this field. They're so lovely and they're so gracious and they're happy to talk with you. And I think that those are the types of things that we've missed more and more in COVID. And so I think, as our world hopefully drips back to some normalcy, that's what I would encourage, folks to do is, don't be afraid to kind of reach out. People really are here and want you to succeed. And it's a great community.
Oh, that's awesome. Well, Robin, thanks very much. And to all the listeners out there, thank you for listening. So I'm going to share now what you need to do to be able to get some of these cool Pentax loops at a great discount. So you must go to pentaxloops.com. So that is pentaxloops.com, and send them an email. Tell them how much you love listening to the Rhinoplasty podcast with Robin Lindsay, and they'll be able to help you out. So, Robin, thank you. So I appreciate your time. Wonderful chatting to you. And just thank you for being the inspiration that you are, not just to the ladies, but to the guys out there. I think it's just fantastic what you're doing. And I would love to come and visit you guys one day once we get over all this COVID, and we'd love to have you in South Africa one day as well.
No, absolutely. And take care. And thank you so much for including me in this. I appreciate it, Cameron.